Hi, this is a talk I gave earlier today at the new Science Past Pupils Association meeting, the first one. It's called ALL. And I had a 15-minute talk on radiology, the cornerstone of medicine. The chair people were Anaga Joshi, Anand Parihar, and Sakshat Matre, all colleagues of mine in radiology, and a diverse, predominantly non radiology audience. And the idea is to show what radiology is capable of. And I started with this example, and this is an old case that I've shown in multiple fora. An 18-year-old pediatrician's daughter who presented with cough and expectoration, and the pediatrician made three mistakes. One is treating his own daughter, treating an 18-year-old, and calling this tuberculosis without proof of disease. 3 months later, on anti TB treatment, the lesion had increased in size with cavitation and cystic change, and he freaked out, got a CT done, and the CT scan was reported as a mass. And the question would have been, what do you think this is? They went to a thoracic surgeon who made the diagnosis and called me asking me to prove it. And I said, all we need to do is a contrast and CT. But then he said that the CT scan center was owned by the pediatrician's brother in law, and it would look really bad if he repeated a CT scan. And the brother in law was the wife's brother, and that's the one you have to be really worried about, not the sister's husband. And so we did an MR, and uh, and this is almost 20 years ago now. When we did the MR, I always used to do a dynamic contrast study. I still do one, and this is the arterial phase here that clearly shows an abnormal supply from the celiac axis into the lesion, telling us that this is sequestration, and that was the diagnosis. So there were three modalities used here: X-ray, CT, MR, that gave us the diagnosis. And that's what radiology is. It's the cornerstone today, around which most of medicine revolves. And these are the various modalities that are completely dependent on some form of radiology. It all started on 8th November 1895 when Röntgen discovered the properties of X-ray to take radiographs like this. This is his wife's radiographs. That's the wedding ring. And then he won the Nobel Prize in 1901. The technology spread like wildfire, and just 2 years later, the army was using it in the US. This is an X-ray with a bullet inside the skull in a soldier. And we use X-rays for dental, OPG, mammography, dual energy absorptiometry. We have X-ray based procedures such as small bowel enemas, angiographies. We use X-rays for interventional procedures. Then in 1971, X-rays were married to computers, and we got the CT scan. And Hounsfield won the Nobel Prize in 1979. And today we have these beautiful HRCT lung images. We can do coronary angiograms, 3D CTs, and then use the data to create live models. We can also use CT to do biopsies, ablations. We can use fluoroscopy units to do a whole bunch of procedures, and that's interventional radiology. MR was developed in parallel. By the mid 80s, we started getting MR scanners across the world. Paul Lauterbur won the Nobel Prize in 2003. And so that gets added to our armamentarium based on Marie Curie's work, and she won the Nobel Prize in 03 and 11. We have nuclear medicine, PET-CT, which have completely revolutionized oncology and oncosurgery at this point in time. And ultrasound, obviously, is the great ubiquitous modality in a country like India, which is used widely for everything from obstetrics to abdominal pathologies to the neck to small parts, etc. And so these are all the modalities that we have in radiology. But this is all anatomic imaging. And what we need to understand is that radiology can do much more. It can go beyond just structure and anatomy and give us information about function, biochemistry, histology, management, and intervention treatment. This is a very simple example of a TM joint where we have a closed mouth and an open mouth, and we've done function. We can see that the disc is moving normally, that the TM joint is normal, and what we've done here is looked at anatomy and structure, but we've also looked at function. 25 years old with thalassemia. This is function. We're looking at the short axis and four-chamber and looking at the contractility of the heart, which is normal. But then we have a multi-echo sequence that shows dephasing in the second echo, telling us that there's extensive and significant iron overload. And we can quantify the iron overload with in terms of T2 star, and this is severe iron overload. We can also look at iron in the liver, pancreas, pituitary, and then this is another patient where we're looking at change over time after chelation agents have been administered to the patient. And you can see in 2 years, the iron has completely gone away from the heart and there is no more iron overload. So we're looking at measuring iron and quantifying iron using MR. So we have structure, we have function as in the contractility of the heart, and we have biochemistry. And in a similar vein, we have this 58-year-old with suspected gout, where we see typical features in the head of the right first metatarsal bone. And then dual energy CT shows these uric acid crystals, and we can see monosodium urate, and use green as a standard color. You can use any color. And you can see that this patient has gout. So that's again anatomy, structure, and biochemistry. We can do histology. 48-year-old with diffuse liver disease has classic findings of cirrhosis. And typically we would do a biopsy to grade the extent of fibrosis. We don't need to do that anymore. MR elastography is good enough, and it will tell us the grade of fibrosis in the patient in a non-invasive manner. And so we can do away with liver biopsies using MR elastography. And so we have both anatomic imaging and histology. This is a 52-year-old with a growing left upper lobe nodule. 207, the X-ray was normal. 18, a focal opacity was seen, slowly growing. And the CT shows an enhancing nodule in the right upper lobe. This is a bronchocele, which doesn't enhance because of obstruction of the bronchus. So middle-aged woman, smooth enhancing nodule with a bronchocele. This is typical of a neuroendocrine tumor. And so we did a DOTA PET because that was a consideration, and it lights up, telling us that there's a well-differentiated neuroendocrine tumor. There was no spread anywhere, and this patient was operated on the basis of this without a biopsy being done. So we have structure, we have function, as in the DOTA showing us the somatostatin receptors, and histology, where we can avoid doing a biopsy in the right patient. Or as in this patient, 21-year-old with a distal radius lesion for a year, biopsy twice. You can see a diffuse distal radius sclerosis, cortical thickening, irregular periosteal reaction. There is this focal lesion here, which is very well seen on the MR. So we then did a dynamic contrast study. We can see rapid uptake and washout paralleling that of the radial artery here, which tells us that we're dealing with an osteoid osteoma. We don't need to do a biopsy. I went ahead and ablated this right away using RF ablation. And so here we have structure, we have function, we have histology determined on the basis of all the structural and functional information. No need for a biopsy, and we went ahead and treated it. Now this is a 32 years old with a glioma, and this is a simple, straightforward tumor. But what we do now is look at the white matter tracts that are involved with diffusion tensor imaging, and then we use functional MR to find out which are the eloquent areas in the brain that need to be preserved during surgery to avoid significant deficits. And this is done with finger tapping or language to find this out. And this patient has this area lighting up, which will not be removed at the time of surgery. So that's functional MR. and we're looking at structure and function. This is a 75-year-old with small airways disease, and we have COPD-like features, so overinflation, air trapping, apical herniation on inspiratory, expiratory scans. We then push these images through Caliper, which is a software that tells us that there's 49% air trapping, 4% fixed hyperlucency, and so we're again looking at structure and function. In screening situations, we even get involved with management. So this is a 62-year-old man with a 25 pack years history of smoking. We saw this patient 10 years ago when we started the screening program. That's the nodule measuring 8.8 millimeters. It's a 4A Langrads nodule, which means 3 months follow-up. But who will do the follow-up? There was no referring doctor involved, and even if there was, they may not necessarily have the incentive to, follow up with the patient, call them over, counsel them. We had to do all that. And then we managed to get the patient after 4 months. The nodule had increased in size. That means the patient needs a biopsy. And again, all of that needs to be done with us. So we had to find the patient's family physician, convince the patient. They finally agreed, did a biopsy, turned out to be adenocarcinoma, and then the patient was treated for that. So structure, it's an anatomic imaging, management of the patient, and intervention. This case was loaned to me by my wife Bijal, who's a breast imaging specialist. 21 screening mammo, nothing. 2024 subtle lesion. The 3D tomomammogram shows it really well. Ultrasound shows the lesion. It was hard on the elasto, so you've got a little bit of functional information. The MR with dynamic contrast also gives us functional information about this lesion. And those are the 3 modalities used: 3D tomomammogram, ultrasound, and breast MR. And then the 4th, an ultrasound-guided biopsy, which then showed that this was invasive breast cancer, NOS grade 2. So again, structure, management, because we had to talk to the patient, counsel them, make them understand what that nodule meant, why it was important to do an MR, and then why it was important to the biopsy. Rope in the referring physician or whoever was their family physician, make them understand, get everybody on the same page, and then move on. And then obviously the intervention with the biopsy. And then here we have a 72-year-old lady with cough and fever. This was during COVID. And then you have automated softwares of different kinds. This was the one we used then. We don't use it anymore now. And here we see this a focal lesion here. And I'm sorry, I got a call, but I'm not going to repeat this lecture. I'm sorry about that. But, you can quantify the extent of disease, measure the aorta, look at bone density, coronary calcium score, and all of that. And as we move on in life, we're going to see more and more of these happening that will allow use of AI and automated softwares to be able to do a lot more stuff and extract more information from the scans that we're doing. So that's structure and automation. So while radiology has been primarily involved with evaluating anatomy, morphology, and structure, it is slowly now able to provide functional information of different kinds. And we can do biochemistry, histology, manage patients, treat, intervene, so many things. It's just not the simple anatomy that we've had with x-rays and standard CT scans. And so we're looking at structure, function, biochemistry, histology, intervention, and management. And the way I see it, the only one complete doctor is a radiologist. And as Harry Mellon said many, many years ago, that the diagnostic radiologist is a clinician who sacrificed one of the greatest glories of practice of medicine, that is the daily contact with the ill and their families. And to paraphrase what he said later, the radiologist perceives the shadow, sees a lesion, and imagines the patient. The physician sees the patient, perceives the signs, and imagines the lesion, though these days the physician just sees the reports and sometimes never even sees the patient, but nevertheless. So physicians practice from outside in, radiologists from inside out, and both are clinicians, for there is no other kind of doctor worthy of the name. Thank you. so much for listening to this and viewing this, and I hope you've enjoyed this.